Now we'd like to open it up for questions. Let me start out with a couple first ones, and while you get ready for yours, and we'll have a microphone for you. Anand, you talked about the global implications here. Take a minute to discuss some of the things that lower income countries, developing countries, how you mentioned the rickshaw driver that has a cell phone. Is this something that they really have only in the cities? Are people in China developing their own apps? How is this helping in other developing countries?
Yeah, it's a good question. The short answer is they are. So if I look at, I'll use India as an example. If I look at India, the wireless community in India is broadly broken up into three categories. It's the tier one metros, the large cities, Mumbai, Hyderabad, Chennai, New Delhi. It's the second level metro, and of course it's the rural areas, so the third circle. Today, the highest growth rate in cellular penetration is in tier three. And it's largely because tier one is saturated. I mean, there's 819 million cellular subscribers in India out of a 1.1 billion population. They're adding 9.5 million subscribers a month to their networks, aggregate networks. And that biggest growth rate, 63%, is actually happening in the tier three. So what they're finding is that they're innovating through the use of distributed antenna systems, outdoor systems. They're creating wireless infrastructure. They're creating local area networks, if you would, in the villages that are providing access and kiosks. So mHealth and the kiosk concept has exploded. It's exploded not just in India. We were in Cape Town at GSMA a couple of months ago in South Africa. And several members of the African subcontinent were describing their programs for malaria, for HIV, for tuberculosis, and just for education. A patient can go to a kiosk that's broadband connected and get access to chronic disease education, which is quite remarkable. And so we are seeing that happening in spades, elsewhere.
Let me also comment on that a little bit. And you see that in a lot of these rural places. There's a wonderful application called EpiSurveyor, which allows community workers who are trained at a center to be able to track immunizations and any outbreaks. And all that is put into the system. It's a free application, and it's used by hundreds of organizations throughout the world. There are examples in Africa where you have problem with resistant forms of tuberculosis and HIV. It gets resistant because you don't take your medications. As soon as you have gaps in your medications, these infectious agents evolve and then become resistant, so you die because you have no more medications. So there's a pill box, which is called SimPill, and you put the pills in it for every day, and you take off the cap, and as soon as they take off the cap, it sends a signal to their cell phone, which is monitored about 500 miles away by a center to see that you took your pill that day. At least you open your cap. And if you didn't open your cap, then you get a call. And what's also nice is that they've developed a charger for cell phones on bicycles. Because it's all nice and well for you to plug in, but a lot of people can't plug in some of these very rural communities, so they're biking around and they're also charging their cell phone at the same time. So even the most rural places can have lots of communication.
If I'd like to just add into a point that Dick made also, Anand, about the compliance. One of the companies that's involved in that's here in town. It's called Voxiva. And they do a lot of work in developing countries, certainly in Africa. I know right now they're very busy with the number of trials with HIV compliance and taking pictures, as you said, and having them transmitted to community health centers 400 or 500 miles away, because it's been shown that if you have to register some kind of activity or action, you're more likely to comply rather than just be out on your own. But what Voxiva's done here in the States, and what we're doing, we're trialing with them, is a program called Text for Baby, where these sensitive or time-sensitive text messages are sent to pregnant women or women who have had recent births. And the idea is that it's aimed toward low socioeconomic women in order to enhance their prenatal care, to give them 2 to 3 text messages every week that would be a reminder of some type, or some kind of advice or some kind of tip about how to provide better prenatal care for their child. Because it's shown that in this country, we're something like 16th or 17th in the world in infant mortality, which is shocking for a country of our wealth and our affluence and our health care. And so can we make inroads with communicating positive messages, value messages to this particularly affected population of women, and then get them to change the health care ultimately of their child and themselves, and also to carry that on post-birth. So great program that's going on at Voxiva. I just give them a pat on the back because they do some fantastic work in that space.
And John, talk about on the spectrum issue, is that primarily an urban challenge? If I live in Montana, do I have spectrum challenges, or is it really countrywide?
Well, yeah, I mean, I certainly would limit to the urban areas at all. I mean, frankly, we have some great opportunity in terms of rural health care. And we think that, and you hit on it earlier, Merrill, I thought it's a great point. It's about improved access, and it's about quality of care, and it's about lowering costs, which really are the pillars of healthcare reform. And that's what we think mobile health can provide. You hit all those three components. But, and we have opportunities to bring improved access to care to rural places. I know in Idaho right now, we spent some time with a community health center out there that's using real-time video consults on robots, where a doctor was in Boise, Idaho, treating a patient in a community health center about 200, 300 miles away, and looking at the sonogram through this robot, through her wireless, high-speed wireless connection. And it was amazing because her face shows up on the screen, she's interacting with the patient bedside, and the patient sees her doctor on the video, and yet that patient was saved the drive of 200, 250 miles. That care was routine. Everything checked out, and the doctor had immediate access to their patient. So it's a great win and another opportunity, I think, or another example of what's happening right now with regard to rural health care and mobile.
And Dr. Katz, Dr. Burgess mentioned the regulations that sometimes can restrict us from the innovations that we want to do. He's talking about federal regulations, but there's also state regulations, and sometimes that comes from the medical community itself. Talk just a second about health IT. If I'm in one state and you're in another state and I want to be able to see you through my computer, my iPad, or something of that nature so that we can communicate, that can sometimes cross state lines and end up creating problems for the ability to be able to deliver that medical care across state lines. What's happening in that sphere?
Well, it's not even necessarily a state line thing. It's actually practitioner or practitioner group or hospital to other hospital. We call it Health Information Exchange, HIE. And in DC, there's the RIO, it's the Regional Health Information Organization, which is trying to let hospitals get information. So an example being, we have a big series of community clinics in town, and those community clinics will get a discharge summary from a patient who is hospitalized 15% of the time. So the patient shows up in an office, and there's a one chance in about 7 that they actually have information about that patient having been in the hospital and what that is and what medicines they were on, and the patient has this sketchy little piece of paper if they brought it with them. So the big challenge is to have my health information system at GW talk to the one at Georgetown or at Washington Hospital Center or elsewhere. We have different systems, but we also have privacy issues, and there has to be issues to overcome. That's a nationwide security issue and regulation, not a state-by-state one by a long shot. And so the challenges of how we share information, patients allowing people to, here's my password, you can have access to it, is the step forward. But at least these systems have to be able to talk to each other. So if I have a patient who's somewhere else and they're sick, they can access their electronic medical record for their physician who they happen to be seeing, and they're traveling in LA that week.
Questions from the audience? Yes, ma'am.
I guess this question could be for everyone, but maybe specifically from the provider perspective from you, Dr. Katz. I couldn't help but notice that the perspective that you gave in your first presentation about talking with the FDA, working with the FDA, and kind of some of the partnerships that have been built on this kind of private-public connection, and then versus hearing from the congressman about all of the kind of regulatory agencies are an obstacle, the ACA is an obstacle, et cetera, et cetera. It sort of seems like those two thoughts are completely disconnected. So I couldn't help but notice that, you know, it seems as if different things are playing out in the political sphere than on the industry sphere. So if someone could just maybe speak to the perspective of how innovation will be moving forward with kind of those two contradictory almost, or seemingly contradictory approaches to working with agencies.
I think the FDA in its initial ruling on the draft guidance was fairly reasonable, was it not?
I have nothing but good to say, even though it was we learned a lot and they learned a lot through the journey. I have a very different opinion than what the congressman expressed, and that is, for some reason, there's an unwillingness to, I mean, as a person, do you believe what you hear or what you see? You always believe what you see. We're doing it. So anybody can talk about, oh, there's no hurdles. There aren't any hurdles. These people are working hand in hand. In fact, they're asking for input. They're asking for comment. You know, tell us where we need to modify. The FDA didn't have a single employee in that group that knew anything about mHealth. They created an mHealth group. They didn't know anything about human factors. They hired human factors people. So here's my parting thought, and that is we can learn from other governments, and here's how. If I look at the BRICS, if I look at Brazil, Russia, India, China as an example, any new technology innovation program, the government plays 3 roles. And there's a number of interesting case studies by McKinsey and Harvard that have looked at this from a public-private partnership. And that is, the first role they play is a catalyst, okay? They catalyze and stimulate innovation by providing grants, by asking people to collaborate across ecosystems. The second thing is they act as a consumer. As Elle said, they drink their own champagne, okay? They eat their own dog food, whatever it is, okay? And then the third thing, now that they've demonstrated it works and it's proven, now they drop the hammer and they legislate, okay? So they're first a catalyst, then they're a customer, then they're a legislator. Here in the US, they often turn that order around. They legislate first. There's no basis for it. And so my request is that we take this slightly different approach to innovation, which is already being proven in spades. It's, again, all you have to do is go to one of these countries and just stay there for 3 days and just learn and listen, and you'll be like, holy smokes, if they're doing it, we can do it too. That would be my perspective.
Yeah, I think the FDA actually did a pretty good job with the guidelines that just came out. Very sensible, we thought. Now I wouldn't say narrowly defined, but certainly very well defined in terms of applications, what would be considered for review, what would not be, what devices would, what would not. We thought that was a really good step. And I know just through our experiences in Text for Baby, our work with the government has been, it's been great. I'm very collaborative. The White House Office of Science and Technology Policy has been involved. Secretary Sebelius has been very supportive. There are probably 3,000 to 4,000 partners now around the country, and state and local governments included in that, state governments included in that. The federal government, Department of Defense is also involved with the trial. So we've had a really good experience in terms of, we think, a pretty unique partnership in terms of public and private, and bringing all those sectors together.
Yeah, I think in fairness to the congressman, the FDA does create some challenges sometimes in various areas because it covers a wide range of things. But as far as the wireless regulation so far seems to be very reasonable. Other questions?
Hey, I'm sorry, I was wondering if the doctor had a comment from the provider
Yeah,
perspective.
just an example. I mean, we're developing with WellDoc a hypertension addition to their diabetes module. We expected to launch that project in the community around August 15th or so, but FDA asked for some review, so we are going to review. We're going to start it in September 15th. There's a month. I'll go on vacation and come back and get it started. So it's not so bad. Again, most of this doesn't. We sort of watch and wait for these things to happen, but this is one of the few instances where I've had to sort of let the FDA sort of weigh in on some of the language we use or whatever the details are, so they're, this next application that we're being trialing looks good for them.
Thanks.
Other questions? Yes, sir.
Hi, my name's Brooks Bolick. I'm with Politico. The figures that you threw out, John, the Rockefeller bill says it's like $6.5 billion for deficit reduction. The last ceiling plan says that they're going to put $15 billion for spectrum auctions of some kind, so that's way under $33 billion. But I guess the value proposition that we're looking at here from the broadcaster point of view, from what they said yesterday, is that, you know, Detroit is going to be left without any full power broadcast television stations at all under the plan. So the question comes, is it worth it for Detroit to go dark for these programs?
Well, Detroit would only go dark if Detroit broadcasters want to go dark. Well, it is. It's a purely voluntary incentive auction, so it's only at a broadcaster's choice should they elect that option. There would have to be some repacking, no question about that. But all that, again, is paid for within the confines of the proposal. So it's not a dime out of anybody's pocket. We think it creates a much more efficient system in terms of delivering care and delivering broadcasting to those who still want that. If you look at spectral efficiency, and I think it's certainly a point worth bringing up, that the United States is at least by twice as much the most spectrally efficient industry, if you will, in the developed world. If you look at our competitors, if you will, Japan, South Korea, Spain, Italy, Germany, France, Spain, UK, Canada, Mexico, we're more than doubly efficient, if you will, than any of those countries. And yet at the same time, they all have at least 2 or 3 times as much spectrum in the pipeline for future use than we do. We don't think that makes sense. And in order for the United States to remain globally competitive, certainly spectrum should be at the top of a priority list. We also think in order to deliver the kind of health care that we're talking about today, that allocation of spectrum, which the FCC has already called for, is certainly appropriate.
If I could just make one comment to that too. I think John's comment about spectrum is spot on, and it's something that if we don't act now, it'll catch us and bite us in the ass, is the honest truth. However, people shouldn't think that there's a trade-off today, so Detroit or any other city going dark because of these types of applications. Just to put real numbers into perspective, if I use my WellDoc application 3 times a day, I'm talking about the transmission of 8 or 10 fields of data. These are narrow-band applications, little bits of data back and forth that may be $3 or $4 a month from a data plan perspective. This is not, you know, sending teleradiology or MRIs or bandwidth-intensive stuff. And so to discuss and suggest that this is a trade-off situation at this point in our evolution, far from that. You know, courtesy of the investments that AT&T and the other operators are making in their own networks, we have plenty of available capacity to do these types of applications and make a dent in healthcare costs right now. But John's point is absolutely valid that we are going to start to evolve these narrowband applications very quickly to broadband applications, and we better start thinking about that now. And hopefully at that point there's resolution amongst these different parties. But today there's certainly no wrestling for that couple of bits and bytes. It's plenty's available.
Other questions? This side? Yes, ma'am.
Good morning. My name is Elizabeth Rojas. My question is, how would all these innovations play a role with insurance companies? Would this be covered? How consumers will be able to pay for all of these innovations, and will this decrease costs for the products in the long run?
Very good question. You've been working with United Healthcare, haven't you?
And I'll let Elle jump in too, because she did correctly mention that we're launching this with HCSC, which is the 4th largest provider. At the end of the day, they're convinced, because they saw the clinical outcomes and they saw that this was a secure, scalable, operational business model. It wasn't just, you know, little WellDoc and, you know, how are you going to cater to 30 million patients? We have the backing of AT&T in terms of how to scale this. They're paying on a per patient per month basis because they're saving dramatic dollars in downward costs that they're going to be experiencing. So what's interesting is there's different models now. There's a model that says I can pay on a per patient per month basis where my customer is the health insurance company, and they're starting to pay, they're starting to adopt it. There are different models that we're pursuing, which are reimbursement. So I'll give you an example. Today, the top 15 drugs in the US that are diabetes drugs, on average, that create a 1.2 A1C reduction are reimbursed $304 per patient per month. If you look at the continuous glucose monitoring and the pump industry, so like the likes of Medtronic, they're reimbursed at $613 per patient per month, and they have a 0.9 A1C on average reduction in their clinical trials. we're making an argument from a fraud, abuse, and waste perspective to CMS that says, hey, if we can actually bundle in a meter and a strip and sell it with WellDoc, right? And now I'll take the burden of giving them the meter and the strip. I'll take that burden away from CMS, so you don't have to pay for it, but I'll bill you when they use the product. I'll bill you when they test. I'll bill you when they have better outcomes. So instead of pay to ship, I'm going to shift the model to pay to test, and of course pay for performance and pay for outcomes. And that's something that the insurance providers are very eagerly looking at, because from that standpoint, they're looking at a deterministic cost basis versus, I don't know what I'm going to spend next year on my claims. Who knows what it's going to be, right?
Yeah, absolutely. I mean, if you think about what health insurers have done in terms of caring for chronic diseases, large case management, that's something they've always been doing for many, many years. But the problem is, up until now, they just didn't have that data. So they would have a list of patients based on lagging claims data. They would make the calls out to the patient, but they didn't have any sense of, is this patient who just happens to have this diagnosis and have this issue and just went to the hospital, are they managing that outcome or not? And they're looking at all sorts of ways in order to reach out to that individual, whether it is through an application or whether it is through text messaging or whether it is through looking at remote care. And as we've reached out to them to share with them our entire mHealth suite, every single area that we've shared with them, they actually are interested and want to learn more, and they want to innovate. And so we're excited about this movement that I think is absolutely in the right direction.
And would the model be that the insurance company just essentially adopts that and pays part of that, so that it bypasses the patient, it just becomes part of the patient's package or the insured's package?
Yeah, you know, when you look at our, you know, how we're used to paying for healthcare, we're just so used in the U.S. to having healthcare costs paid by somebody else. And when you ask the man or woman in the street, you know, how do you think about your co-pays and deductibles? They have no idea. You know, it is just, you know, part of what they come with their benefits. And we recognize that from an employer perspective, they're bearing that cost. And so it is very important now to have these interventions that link in with a nurse case manager or within a hospital situation with their care provider in order to provide that feedback loop. And it all drives towards improved care outcomes, reduced costs, improved efficiencies of how you use the doctor and the nurse's time. I was in a panel previously where one of the docs said, you know, one of our goals is I want to be able to spend time with my patients. I want to do that in a high quality way, and I want to be able to do that so that when that patient is away and in their home, they're still being monitored and having that peace of mind to know that those results are coming back to me.
And it raises an interesting question, because most people think of health insurance, but for larger employers, the larger employer may use a health insurance company to shuffle the paper, but the employer themselves is actually making the payment. They're self-insured.
Absolutely.
So are you reaching out to employers as well as insurers, like a Walmart or the large employers?
Yeah, you know, actually, we're reaching out to the entire ecosystem. I mean, early on, I can't remember who it was. Maybe it was Dr. Katz who was saying, you know, you have the patient in the middle, and you've got all the different ecosystem players. You've got not just the health insurance, but you've got the pharmaceutical, you've also got the, you know, the retail pharmacy, you've got the family members. And what we need to think about mHealth is there needs to be clarity on who pays, and the person who pays is the person who bears the medical costs. But then when you're marketing this, you need to market it to all the constituents, because you need all the constituents within that ecosystem to rally around and to use this in order for it to have that impact.
Other questions? Yes, sir.
This is sort of a piggyback off of the very first question that was asked, but I guess currently there's only a limited number of devices that have been approved by the FDA so far, mobile health devices. Do you think that with the regulations that have come out, or do you think that with the regulations that have come out, that we'll start to see a lot more announcements of approved devices, you know, kind of a flood of innovation, because people will know, you know, what direction to go in at this point?
Good question. Who can take that?
I think the short answer, Dan, is yes. And I think the primary reason is because they've put a little bit of structure around what was otherwise nebulous. So people now I mean, just to give you an idea of how crazy some of the discussions were, rewind the clock by a year, and people were, discussions, regulatory discussions, saying, so you're connecting data from a blood glucose meter to a cell phone. Okay, well, the cell phone's an accessory. And I'm like, okay, I can buy that. Well, but the cell phone then opens a data channel to the internet. Well, the internet's an accessory now. And I'm like, oh, wait a minute. You know, since when did the internet become a medical regulated device? That was where it started, right? It was that nebulous. Now, when you look at the guidelines, it's actually quite clear in terms of when you look at it from a regulated and an unregulated standpoint, and a prescriptive and a non-prescriptive. So think of a classic 2x2 that has these two dimensions. And it's actually quite clear as to the types of protocols they want to see, the types of quality systems measures they want to see you implement. So it's not just what your product is, it's the process by which you developed your product, repeatable, scalable. We just had our first inspection from the FDA 6 weeks ago, 8 weeks ago, and it went really well. And they look at not just what you did, but how you did it, the processes, the documentation, et cetera, because they want to ensure what you're putting out is a quality product. They want to ensure that if there is an issue, you know how to handle that issue and you know how to address that issue such that you're optimizing patient safety. So I think you will see a number, now that they've issued at least initial guidelines, I think you will see a number of people saying thank you. Now I know what to do next.
Yeah, and to layer on, I think the issue isn't so much, you know, are we going to see more innovation? Are we going to see more applications? Because you do have a very crowded marketplace today, and in fact, the problem is that you probably have too crowded a marketplace where there are too many out there that are Me Too's, and they are siloed, standalone, or they are, no better than an e-log. So the question is, how do I create a situation where I can enable the applications to connect onto a back-end system so that they don't all have to, reinvent and redevelop by dint of necessity their own back-end platform? And how do I ensure a situation where these applications can connect to legacy healthcare ID systems, which, to date, it's hard to connect to, and some of these ID systems are very closed. And I think it's a situation of, if we can enable those applications to connect better to our legacy healthcare ID systems, so I'm talking about your claim systems, your member systems, your EHR systems, and at the same time, also create the common shared infrastructure so that mHealth application developers don't all have to develop their own, and then more importantly, allow for these applications to interchange and exchange data across them so that they're no longer silos. That then I think is that game changer.
Well, we've come to the end of our time. We've got to turn the room over. IPI has been videotaping this. This will be available on our website soon at www.ipi.org. Feel free to come up and visit with the speakers if you'd like to get their card, talk to them for just a second. Feel free to grab a bagel or a muffin on the way out. And thank you so much for joining us, and help me join me in thanking the panel.
What I was going to say.